Hi, I'm Joni Watson, and today I'd like to share about primary and secondary prevention of colorectal cancer. Rather than say colorectal cancer over and over again, you'll likely hear me call it CRC for short. But no matter what I call it, I hate it. On Father's Day of 2010, my youngest, and dare I say coolest, guitar pickin', Dallas cowboy hatin', tell a joke like nobody's business uncle died of colon cancer after being diagnosed only a few weeks prior. He was 53. You, your family, anyone's family should know more about colorectal cancer, know their risks, as well as screening guidelines. And within this activity, we'll cover both primary prevention, meaning what we all typically think of in regards to prevention, diet and exercise, those kinds of things, as well as secondary prevention, meaning colorectal cancer screening. Now, tertiary prevention, which includes treatment and survivorship, is absolutely important to improving the health of patients. And all nurses, no matter their specialties or roles, can impact colorectal cancer. But for the purposes of this educational activity, we'll discuss primary and secondary CRC prevention. So let's take a good look at the overall picture of CRC, not only in the U.S., but also globally. According to the American Cancer Society, over 1.6 million people are expected to be diagnosed with cancer in this year alone in the United States. Of those cases, almost 9%, or 141,210 people, will receive a diagnosis of colorectal cancer, making it the third most prevalent cancer among both men and women. While colorectal cancer deaths have declined slowly over the last 20 years, deaths from CRC still make up close to 9% of all cancer deaths. And males are diagnosed with CRC slightly more often than females, and African Americans bear a disproportionate burden of the disease, often being diagnosed later and with more aggressive forms of CRC than their white counterparts. Jews of Eastern European descent, or Ashkenazi Jews, also have higher incidences of CRC as a result of genetic mutations. Globally, there are approximately 600,000 new CRC cases annually, second only to lung cancer. Colorectal cancer is largely a disease of Western developed countries, although there may be gross underreporting in developing countries. Within the United States, CRC rates are generally higher in southern states than in northern ones. CRC screening rates continue to improve across the U.S., with 65% of eligible people screened appropriately in 2010, a significant increase from 52% in 2002. No surprise that states with higher screening rates have lower rates of CRC mortality. Still, though, only 65% of eligible people are being screened for colorectal cancer. Why is that? We'll talk more about it in just a moment. But certain populations are less likely to get screened for CRC. For example, colorectal cancer screening rates are lower among African Americans and certain Asian American and Pacific Islander groups, in particular Koreans, Filipinos, and South Asians. Lack of knowledge about screening tests and lack of healthcare professional recommendations for ongoing screenings continue to be large barriers, even for those with access to insurance. And that's where we can come in as nurses and make an impact. Let's discuss a little bit more about the anatomy and pathophysiology of colorectal cancer. CRC is any cancer originating primarily within the colon or rectum. Such cancers can be referred to separately. We can call them colon cancer, we can call them rectal cancer, or we can put the names together and call them colorectal cancer. It can occur as a result of an inherited mutation or may occur spontaneously as a result of various risk factors. In order to fully understand colorectal cancer, it's important to be familiar with the anatomy of the system affected. So the GI system's work begins as food is chewed. It passes through the esophagus and enters the stomach, and once food is partially broken down, it continues to pass through the small intestine where the majority of nutrients are absorbed. The small intestine then connects to the large intestine, or colon, and the colon, which continues to absorb nutrients and water, and then forms and holds the stool. That consists of 4 parts: the ascending, or right colon, the transverse, or middle colon, the descending, or left colon, and lastly, the sigmoid colon, which is known for its S shape. The last 6 inches of the GI system is the rectum, which holds stool for passing from the body. And the colon has numerous layers, and colorectal cancers actually begin to grow on the inmost layer and then spread through the outermost layers. It's really important when we talk to patients about colorectal cancer that we think about what kind of language that we use. Even though we may understand what the colon is, patients may not. And so you need to adequately assess patients' understanding and think about health literacy levels. I have a friend who, when she educates about the GI system and the effects that chemotherapy has on the GI system, she says that the GI system is anything from the entry point to the exit point, and she's quite animated about it, and it gets patients' attention. But just because you say colon cancer, it doesn't mean that a patient actually knows what the colon is. So perhaps a picture or further assessing would be helpful in that education. Early stage CRC rarely has any associated symptoms. Typical signs and symptoms of CRC are often dismissed as trivial, and that delays provider assessment and diagnosis until later stages of disease. Common signs and symptoms of CRC include diarrhea, constipation, narrowing of the stool lasting for a few days, feeling an unrelieved need or urge to have a bowel movement, dark or bright red blood in the stool, cramping or abdominal pain, fatigue, and unintended weight loss. While these symptoms may be indicative of non-malignant concerns, it is important for anyone experiencing these symptoms to consult a healthcare provider. All right, so here's the primary CRC prevention piece, what we all typically think of in regards to prevention. And colorectal cancer has both modifiable and non-modifiable risk factors. So as is true with most cancers, CRC risk increases with age. An overwhelming proportion of colorectal cancers, 90% actually, are diagnosed in people age 50 or older. Thus, our screening begins at age 50. A previous diagnosis of colorectal cancer, or having intestinal polyps or inflammatory bowel disease such as ulcerative colitis or Crohn's disease, increases a person's risk for future CRC diagnosis. Similarly, a family history of CRC should be assessed carefully because there are numerous inherited syndromes associated with colorectal cancer, including familial adenomatous polyposis, or FAP, hereditary non-polyposis colorectal cancer, also known as HNPCC or Lynch syndrome. In addition, there are syndromes such as Turcot syndrome and Peutz-Jeghers syndrome. About 7% of all CRC diagnoses are due to these inherited syndromes. FAP and Lynch syndrome are by far the most common inherited syndromes. Individuals with FAP often develop hundreds or even thousands of intestinal polyps throughout their lifetimes, with at least one cancerous lesion appearing before the age of 20. Lynch syndrome, on the other hand, accounts for roughly 2 to 5% of all CRCs and also develops in younger individuals. Persons with Lynch syndrome have far fewer polyps than those experiencing FAP, although Lynch syndrome polyps become cancerous more frequently than those associated with FAP. People with Lynch syndrome are also at an increased risk of other cancers, including endometrial, ovarian, and kidney cancers. Turcot syndrome is a rarer disorder also associated with an increased risk of brain cancer. And individuals with Peutz-Jeghers syndrome typically develop polyps at a younger age and may have identifying freckles around the mouth or on the hands and feet. Both African American men and women continue to have higher incidences of CRC cancer and are often diagnosed at later stages and with more aggressive cancers than their white counterparts, even when adjusting for socioeconomic and health insurance statuses. The actual biological differences in CRC tumors among some ethnicities remains unexplained. However, there are known genetic linkages to increased colorectal cancer. For example, Ashkenazi Jews are at increased risk of colorectal cancer because of several documented genetic mutations. The most common APC mutation is found in 6% of American Jews. Obesity is an important contributor to CRC, and researchers are learning more and more about the link between obesity, which is the combination of poor diet and inadequate physical activity. Aspects of poor diet include consuming more calories than expending, leading to weight gain, eating fewer than the recommended 5 or more servings of fruits and vegetables per day, low fiber intake associated with refined grains rather than whole grains, and consuming large, meaning more than 3 ounces, of red meat daily. Consumption of red meat, processed meat, and meats cooked at very high temperatures is linked to higher incidence of CRC, perhaps related to ingestion of heme iron, nitrites, and nitrates within the meats. Obesity seems to pose a greater CRC risk for men than for women. I have a clinical dietitian on my team, and she comes across this question often. When she talks to patients, and I can hear her voice in the back of my mind, she tells patients, yes, be careful of your red meat consumption. The evidence is a little weak on that, actually. The evidence is stronger in regards to the protective factors of fruits and vegetables. So if you want to eat some red meat, you need to have some red meat in your life, eat your red meat. But definitely get your 5 to 9 servings of fruits and vegetables per day. In regards to physical activity, for adults, it's defined as 30 minutes or more. 45 to 60 minutes is actually preferred, of moderate to vigorous, intentional activity, 5 or more days each week. The recommendation for children and adolescents is for a minimum of 60 minutes of moderate to vigorous physical activity at least 5 days per week. In addition, the American Cancer Society recommends maintaining a healthy weight throughout life by balancing food intake with physical activity and consuming a healthy diet with an emphasis on plant-based sources of food. Tobacco and alcohol are also known contributors to CRC risk. Smoking and tobacco use have been conclusively linked to 15 different cancers, including colorectal cancer. Because the known carcinogens are often swallowed or circulated to the digestive system, the CRC risk is greater for those with a longer history of tobacco use. All patients who use tobacco should be encouraged at every provider encounter to stop tobacco use. The role of alcohol consumption in increasing CRC risk is still unclear, but researchers at the Agency for Healthcare Research and Quality, or AHRQ, believe alcohol changes specific metabolic pathways that increase cancer development risk. Men should follow recommended guidelines to drink no more than 2 drinks per day, and women should drink 1 alcoholic beverage or fewer per day. Those who do not drink should not begin. Many of these modifiable risk factors are also risk factors for type 2 diabetes. However, type 2 diabetes appears to be an independent risk factor for CRC. Even when other risk factors are taken into account, individuals with a type 2 diabetes diagnosis are more likely to be diagnosed with colorectal cancer and to have poorer outcomes after diagnosis and treatment. All right, so now we're starting to transition to the ongoing screening according to recommended guidelines. That remains one of the strongest prevention strategies against colorectal cancer. Screening is inversely correlated with cancer incidence and mortality, meaning as colorectal cancer screening increases, incidence and mortality of the disease actually decreases. Because of the lack of early signs and symptoms, physical screening is necessary to diagnose CRC early. Genetic screening is also an important tool for people at risk for inherited syndromes. There are numerous tests to indicate CRC. There is some research indicating vitamin D may be protective for CRC, although much more research needs to be done in this area. And the literature supporting aspirin as a chemoprotectant for CRC is growing by the day, it seems. In addition, Estrogen is linked via studies as a possible prevention strategy for CRC, although it's important to note the risk for breast cancer may actually outweigh the benefit for numerous individuals. Let's talk about the specific CRC screening tests. There is a wide variety of CRC screening tests and procedures available. Invasive CRC screening procedures include colonoscopy, flexible sigmoidoscopy, and double contrast barium enema. Colonoscopy and sigmoidoscopy involve physically envisioning parts of the gastrointestinal system. Non-invasive CRC screening tests include virtual colonoscopy, fecal occult blood test, or FOBT, and fecal immunochemical test, or FIT. Stool DNA test was formerly an option for screening, but it's no longer a recommended screening guideline. Virtual colonoscopy uses imaging, while the other non-invasive tests involve stool sampling. The invasive procedures and CT colonography, or virtual colonoscopy, can detect polyps and all require a cleansing bowel preparation in order to fully visualize the screened areas. Some may actually require anesthesia. The FOBT and FIT tests can identify existing cancer, but cannot identify existing or growing polyps, which are precursors to CRC. Because of this, the first 4 tests are preferred if available, though some patients might prefer the non-invasive procedures. Selection of screening tests may be impacted by personal beliefs and attitudes, healthcare provider knowledge, attitudes or skills, including training, accessible services, and even insurance coverage. Medicare and most insurance companies now fully cover screening colonoscopies as a result of the passage of the Affordable Care Act. Still, diagnostic colonoscopies and anesthesia services may or may not be covered, leading to larger out-of-pocket expenses, which may impact screening habits. Colonoscopy remains the gold standard, definitive screening and diagnostic colorectal cancer test. It's also the most thorough. A colonoscope, or thin tube with a camera on the end, is used to view the entire colon, as well as to remove for biopsy any polyps or suspicious lesions. If any of the non-invasive screening tests indicate the need for further inspection or the need for polyp removal, a diagnostic colonoscopy will be performed. A flexible sigmoidoscopy utilizes a similar tool, a sigmoidoscope, to visualize the sigmoid colon. The provider can view the entire rectum and the lower half of the colon using this procedure. In addition, the provider can remove any visible polyps. Polyps or cancers growing higher in the colon may not be identified using this test. If polyps removed during this procedure are found to be malignant or precancerous, a colonoscopy will be conducted at a later date. For these reasons, it may seem that a colonoscopy is always preferable, but numerous provider, patient, and healthcare system factors influence the selection of screening tests. The advantage of these 2 tests is that it is possible to both identify and remove adenomatous colorectal polyps during the procedure. A double contrast barium enema, also known as the lower GI series, is another test in which the bowel is cleansed and barium sulfate and air are distilled into the colon through a small flexible tube. The patient is then physically turned in order to diffuse the air and barium throughout the colon. X-ray is used to visualize any abnormalities of the colon lining. If polyps or suspicious lesions are identified, a colonoscopy again will be done for removal and definitive diagnosis. In regards to the non-invasive screening tests, virtual colonoscopy is a newer method in which a CT scan is used to take continuous scans of the patient's colon. The images are combined into a 3D image that will identify polyps and other abnormalities. Virtual colonoscopy requires a cleansing bowel preparation, and as with other screening tests, if any suspicious findings are located, a colonoscopy is needed for definitive diagnosis. The FOBT, or guaiac hemoccult, may be done in the privacy of an individual's home. This test requires 3 different stool samples, which are tested for occult blood from small bleeding polyps. A perceived disadvantage of the FOBT has been that a restricted diet was required beforehand to avoid false positive results. However, a meta-analysis found no significant difference in false positive results for patients who restricted their diet and those that did not. Because dietary restrictions may impact adherence to FOBT completion, nurses can increase patient compliance by sharing this information with other healthcare professionals. It is also important to remember that stool samples collected as part of a digital rectal exam are not sufficient. Nurses may need to educate and empower individuals who are uncomfortable collecting their own stool or applying it to the FOBT screening test card. I recently had personal experience with conducting an FOBT test for anemia, and I took the FOBT card home. I thought, no problem. I have collected more stool samples than I can even count. It should not be a problem collecting my own stool. And then I got home and had to collect my own stool, and it was not a fun process. And in addition, I've been married to my husband for almost 14 years. I was frantically looking around my bathroom where to hide an FOBT card for the next 3 days. That's not something that I wanted my husband to see or experience. And I thought to myself after that experience personally, if I'm a registered nurse and I'm comfortable collecting body fluids and stool, and I know how important FOBT is, not only for colorectal cancer screening, but for screening all sorts of other chronic diseases and conditions, if I have this much difficulty with an FOBT card, how do my patients feel? Gave me a completely different perspective and one that I can share with patients now. So be cognizant of when you educate patients about collecting their own stool. It's not as easy as it may seem. The FIT test is also sometimes referred to as the IFBOT, or immunochemical fecal occult blood test. This test works by reacting to the human hemoglobin protein present in blood in the stool. This test may be preferred because it does not require the dietary restrictions needed for the FOBT, and because fewer stool samples may be required. It is important to remember that neither the FOBT nor the FIT test detect non-bleeding polyps or CRC tumors. The sDNA or stool DNA test was formerly included in recommended screening guidelines as another screening option. It identified genetic mutations that often lead to colorectal cancer. As of early 2013, though, the sDNA test is no longer available within the United States and therefore no longer part of recommended screening guidelines. Persons who have had cancer at a young age have had 2 or more separate cancer diagnoses, or those with several family members impacted by cancer may benefit from genetic testing and/or counseling by a certified genetic counselor. Genetic screening for CRC is a blood test typically done for high-risk individuals. If a certified genetic counselor does identify a hereditary syndrome, those individuals should have earlier and more frequent CRC screening, as previously discussed. Patients may fear that the results of genetic testing might impact current or future employment and health insurance coverage. However, discrimination on the basis of genetic testing and results by employers or health insurance companies is prohibited by the Genetic Information Non-Discrimination Act, or GINA, which was passed in 2008. According to the American Cancer Society and the National Cancer Institute, both men and women at average risk for CRC should begin routine screening at age 50. Average risk individuals may undergo one of the following: a flexible sigmoidoscopy every 5 years, or a colonoscopy every 10 years, or a double contrast barium enema every 5 years, or a virtual colonoscopy every 5 years, or an FOBT every year, or a FIT test every year. If any screening test is positive, a colonoscopy will be needed to ensure definitive colorectal cancer diagnosis. High-risk individuals include those with inherited syndromes such as Lynch syndrome, FAP, and those with inflammatory bowel disease, which together account for approximately 10 to 15% of colorectal cancers. Other high-risk individuals, roughly 23% of CRC diagnoses, are those with a previous history of CRC or intestinal adenomas, a first-degree relative with a history of CRC, or a personal history of breast, ovarian, or endometrial cancer. High-risk individuals should begin their screening practices earlier than age 50 and speak to a healthcare professional about when to start and how frequently to get screened based on their respective risk categories. Screening proponents argue that the best CRC screening test is the one that gets done. Nurses should speak with patients and their families about the recommended evidence-based screening guidelines, follow-up tests that may be needed if screening comes back with positive or suspicious findings, and any attitudes or beliefs that may lead to non-adherence to recommended screening guidelines. Providers should not insist on invasive testing to the point that patients avoid screening altogether. In addition to regular CRC screening, changing the modifiable CRC risk factors mentioned above by increasing fruit and vegetable consumption, decreasing consumption of red and processed meats and alcohol, quitting tobacco, and increasing physical activity are positive and effective prevention strategies. Some prospective studies have suggested a link between vitamin D deficiency and colorectal cancer and proposed that individuals should increase their consumption of vitamin D. However, the National Comprehensive Cancer Network, or NCCN, an organization of 21 leading cancer centers, does not recommend this because evidence for this strategy is lacking. Similarly, new research indicates that regular use of nonsteroidal anti-inflammatory drugs, or NSAIDs, such as aspirin, and menopausal hormone therapy help reduce inflammation that may lead to colorectal cancer development. As with vitamin D, the evidence surrounding NSAID and menopausal therapy as chemoprotective agents is still inadequate to adopt their use as a standard preventive strategy. Of note, the breast cancer risk posed by menopausal hormone therapy may actually outweigh the CRC protective benefit. Nurses are key to improving health and wellness for all, including colorectal cancer survivors and their families. Nurses can affect the public's awareness and willingness to use screening measures that can detect CRCs early, increasing the opportunity for cure and survival. There are numerous opportunities for nurses at all levels to affect colorectal cancer and help reduce the impact it has on our patients, friends, and family members. Because it is the third most common cancer among men and women, there are many available evidence-based and reputable resources for nurses and our patients, which are listed at the end of this education activity. Thank you.